So welcome everyone. We are here at the Radiology Specialist Interest Showcase. This is session number 5, which is the Nuclear Medicine and Breast Imaging Showcase. And I'm Amy, one of the radiology registrars from the Northern Deanery, specialising in nuclear medicine training. We've got a really interesting series of speakers for you this evening. I'm just going to talk first about the Specialist Interest Showcase. So this is basically just to highlight that as a radiology resident, there can be confusion about what direction to take in subspecialty training. There can be quite a lot of uncertainty about the future and what subspecialties will be like as you kind of go through your training. You can have quite limited exposure during training to the scope of practice and opportunities available out there. And that's why we're doing these sessions this evening. We really want to inspire, the next generation of radiologists and make sure that you've got all the opportunities possible. And this series really is just to make sure that we can add and fill any gaps, answer any questions that you have to make sure that you know the landscape of all the fields when you're making a decision about what subspecialty to do. So these are learning outcomes from these sessions that we've been doing monthly since the new year. Main thing is really to facilitate discussions on different specialty interests and where they might go in the future, kind of looking forward, and then also reflecting on the role of radiologists and within that subspecialty interest. Just want to say a quick thank you to the team who's put these sessions together. So that is the Radiology Resident Doctors Forum, which I'm a part of, and also the Royal College of Radiologists, with these people specifically mentioned to give our special thanks to. And then also, we're really thankful to our speaker faculty and special interest groups, because without them, these sessions wouldn't be able to go ahead. So the format is basically a Zoom session that you're all in, and we're trying to cover 14 subspecialist interests, 2 of which will be tonight, nuclear medicine and breast. Obviously, we've got kicked off at 6 p.m. We expect to finish about 7:15, and between 7 and 7:15, that will be the Q&A session. So write down any questions that you might have. We'll record the session so you can make the content available so you can rewatch them if you need to. You may have seen the January to April sessions, but now we've moved on to the May session, and then we've got June and July upcoming. Session 6 being head and neck and thoracic radiology, and session 7 in July being education, training and research. So please join us for those sessions if those are of interest to you. So without further ado, just want to open the session, and I'm going to be introducing our first speaker. So just bear with me whilst I stop sharing my screen. So our first speaker this evening is Dr. Charlotte Fowler. But before we begin, I'd just like to note that Dr. Sabina Dezarvek is unfortunately unable to join us this evening due to unforeseen circumstances. We send her our best wishes, and we're very grateful for Dr. Charlotte Fowler for kindly stepping in to present tonight, especially given the late notice. Dr. Charlotte Fowler is a radionuclide radiologist with a distinguished career spanning several leading centres across the UK, including Cardiff, Royal London and Cambridge. Her clinical work has taken her from Medistic General Hospitals to specialised cardiac centres and major teaching hospitals, with consultant posts at Luton and Dunstable, Harefield, Brighton University Hospitals, and most recently, Guy's and St Thomas's. Now, recently retired from full-time clinical practice, Dr. Fowler remains highly active in the field. She currently serves as chair of the Nuclear Medicine Specialty Advisory Committee and is deputy lead of the newly established Nuclear Medicine postgraduate programme at Brighton Sussex Medical School. Outside of medicine, she's an enthusiastic sailor and skier, I hear. She admits sailing may be her favourite.
So, Amy, thanks so much for the kind of introduction, and apologies everyone that this is a little bit hot off the press because I have been asked to step in at last minute. So any spelling mistakes, please forgive me. So just to say, it's a delight to talk to you. And I remember very clearly, although I'm obviously very ancient, I remember very clearly sort of trying to work out what I was going to do. I was so lucky that I trained in Cardiff, and every morning we would go to Dr. Reese's office and look at the nuclear medicine images from the previous day. And I think that's probably why I ended up doing nuclear medicine, just because of the opportunity just to see the range of stuff. So anyway, I'll talk on now. So I hope you can see my talk, my screen here. I'll just carry on and hope you will. And apologies for my useless voice. So what is nuclear medicine? Excuse me. A lot of you will know this from your part 1 FRCR because there's quite a lot of nuclear medicine in the first part, but it's the use of radioisotopes for medical diagnosis or medical treatment. And why do we need it? Because we've got all these other brilliant modalities. And why do we need it? And it's because some pathologies are occult on other imaging modalities. And by using the physiological concentration of tracers, we can then identify disease or other processes. And we can also use nuclear medicine to quantify and track. So the basis of nuclear medicine is basically the use of a radioisotope which emits radioactivity, either in the form of energy as photons or particles. And in nuclear medicine, the whole range of nuclear medicine, we can use all of those aspects. We can use the functional imaging, can use the energy, the photons that are emitted can be identified using a gamma camera, and those images can either be made into planar or SPECT images in the 3-dimension, and also can be used for quantification. And the particles that can be emitted can be used for molecular radiotherapy. Okay, so the key to nuclear medicine and the exciting part of nuclear medicine really is the tracer, which we then have attached to the radioactive atom. The tracer can be chosen or designed now with kind of nanotechnology, designed specifically to concentrate in a particular biological process or tissue. And that is then chemically attached to the radioactive atom in the radiopharmacy. And then the combination of the tracer and the radioisotope are injected or given to the patient in some other way. And they can be imaged using a gamma camera or PET camera. And the isotope is chosen for its characteristics, its photon emission, its half-life, for example. And really, there are limitless opportunities for the development of new tracers. And this leads to a huge variety in what we can offer. So instead of CT just having iodinated contrast medium or MRI having gadolinium, we just have the whole range of different tracers that we can use. So this is just a list of all the Royal College of Physicians medical specialties. And I just thought I would use this as a way of kind of showing the overlay that nuclear medicine has on the different sort of pathologies that can happen. So there's cardiology, where we do myocardial perfusion, scintigraphy, and MUGA scanning for function. Endocrinology and diabetes, we have all the endocrine imaging. So we've got very strong opportunities to identify thyroid disease, parathyroid disease, neuroendocrine disease. We have strong offerings in gastroenterology with gastric emptying, transit studies, HIDA, CCAT studies looking for biliary problems. And then, of course, in renal medicine, we have renography, geriatric and neurological studies. We have dementia. We've got very strong tracers being developed now, which actually are able to identify the Alzheimer's plaques. So that is very exciting development. And well, I don't need to go through the rest of them, but you can see that there's an awful lot of coverage here. So one thing that nuclear medicine certainly is not is locked into one particular referral group. And I think that's one of the things that really attracted me to it, was the fact that I would be dealing with consultant colleagues from across the spectrum of medicine and of course surgery to help them with their patients. And it was that breadth that nuclear medicine seems to give that was particularly exciting to me and has been very rewarding. So what attracted me to nuclear medicine, like I say, the variety involving most medical specialties and surgical specialties, you know, it's just the full breadth, really. I like the lateral thinking, the fact that form doesn't always mean a particular pathology, and that we sometimes have to really think very laterally to work out the diagnosis. There are wonderful research opportunities in nuclear medicine, and that's mainly because of the quantification opportunities, because instead of just creating images, I mean, we do create images, but those images can actually be quantified, and that means that's terribly helpful for creating research results. We have a really broad team, and that doesn't only involve us as radiologists or nuclear medicine physicians and nuclear medicine technologists, but also includes very important colleagues in our departments who are the physicists and radiopharmacists. And that creates a bigger and broader team, and we have wonderful help and support from, you know, a whole range of different colleagues. And that kind of multidisciplinary team is very much a feature of nuclear medicine, and another thing that's very rewarding about it. And it's rapidly evolving. So when I started nuclear medicine, you can see I'm gray-haired here, and I'm very old. I've just retired. So of course, when I started in nuclear medicine, it was a long, long time ago. And these were the kind of images that we were commonly dealing with. Planar images, still very rewarding and interesting. You know, they generally hold a lot of information in the same way that a chest X-ray does. So very challenging to report, and actually with the new technology of SPECT and SPECT-CT, things have actually got a bit easier. But of course, a lot of our tracers are not very specific. So this is looking at a bone scan, which concentrates in the osteoblasts. It's a phosphate-based tracer. And these are all the different things that it could be. So we just need to make sure that we kind of keep our lateral thinking awake, and don't always opt for a particular diagnosis. I mean, this could be a solitary metastasis, or it could be something else. And of course, we use radiology to help us work out what's going on. This is a posterior image. So just to remind you that nuclear medicine images from the posterior aspect, this will be the patient's left. This is an X-ray that goes with it. So this is the corresponding lesion, and it shows very nicely degenerative changes with gas in the reduced disc space, osteophyte formation, sclerosis are on each side of that. So this is just a solitary degenerative joint, which has been worked out from planar images and an X-ray. Now, at the other end of the spectrum, we have the development of nanotechnology, which has allowed, for example, DAT scan. You'll recognize this as a synapse, and this is part of the dopamine synaptic pathway. And the clever folks in the labs developed a tracer that would attach to the reuptake transporter agonist here. So when the synaptic space is hoovered clean, this is the molecule in the membrane, which then locks into, is upregulated or downregulated depending on whether the patient has disease or not. And in the same way that we have a perfectly normal brain CT here, a very abnormal DAT scan can be used to demonstrate that this patient does indeed have Parkinson's disease. So as part of my long career, I've seen the technology develop. So when I first started, we were doing we did have SPECT cameras, but if we wanted to work out what was going on, we would actually have to do a SPECT scan and a CT scan and merge those in our minds. Of course, now with SPECT-CT cameras, such as this one, the CT component is at the back, the gamma camera is at the front. The two modalities are not actually merged, but they're attached, and then that produces this marvelous combination of function, and anatomy, which helps us work out exactly what's going on with patients so frequently. And this has developed more and more. We have now sort of state-of-the-art imaging with PET-CT and SPECT-CT cameras and marvelous tracers. And it's really been a swiftly progressing aspect. And there are new tracers coming on board, which I'll go on to talk about. In the past, molecular radiotherapy has been used really for a very long time. Since the 1950s, it's been used. So it's a very early form of therapy for thyroid cancers. More recently, neuroblastoma, neuroendocrine tumors, but these are all rare diseases and were sort of well supported by sort of specialized centers scattered about. This is all set to change now with the development of a specific tracer for a very common disease, which is prostate cancer, with the development of a tracer which is prostate-specific membrane antigen. And PSMA labels can be labeled with both PET or SPECT isotopes for the diagnosis of disease burden, but that same tracer can then be labeled with a therapy isotope, which is lutetium, for treatment. And theragnostics is a term that is increasingly being used for the tailoring of therapy based on disease burden assessment using the same tracer. So you use the same tracer for the diagnosis and then change the isotope to a therapeutic one. So we anticipate a huge increase in demand, of course, because prostate cancer is so common. And the technology challenges of having scanners that are rather slow and are subject to sort of movement artifact and all the other things that happen with slow acquisitions are being addressed. So we have now got large field of view and total body PET-CT scanners, which are incredible, and they image better and they image faster and they image with a lower dose and then longer and later and early and late, and total body coverage is happening, and it's an exciting time. And here are some examples of image acquisition that have only taken a minute to acquire or 30 seconds to acquire. And that, of course, that same technology can be used to have a scan of a normal quality, but using a 20th of the usual radiation dose. So very exciting progress in terms of our technology. So I would argue that nuclear medicine has all the components needed for a truly satisfying career. There's a lot of demand for it. It's intellectually stimulating, it's progressive, and there are wonderful research opportunities. But we must always remember that actually it's the patients and the human aspects which make any career really satisfying. So just a reminder of that, and also a reminder of the breadth and size of the nuclear medicine team, which tends to make for a very satisfying life-work balance. And this is the lovely Sabina, who I'm sorry is not with you at the moment. This is her department in Brighton. So just to quickly cover, because I'm aware that I'm running out of time, the training challenges. So nuclear medicine is very closely regulated, and we have this thing called ARSAC, the Administration of Radioactive Substances Advisory Committee. It sounds very scary. It has a certain power because it can stop departments functioning. Basically, it is up to the committee whether the necessary structures are in place to ensure safe nuclear medicine services for patients and for staff. So these are the notes for guidance, and is basically the Bible for people who actually want to lead nuclear medicine services. There are two parts to an RSAC license. There's the employer's part, so that includes proof from the physicists who are running, leading from that side of things, that all the equipment is good quality and everything is in place in terms of staff training. And then on the medical side of things, there is the medical RSAC holder, and they act as the practitioner under IRMA. So it's quite a unique thing. There aren't many other areas of radiology where there's such stringent kind of guidelines. So they have very stringent requirements in terms of education and training, which is kind of case exposure. And they will insist on seeing that before awarding a practitioner license. And that is required to lead any radioisotope service. So I lead the nuclear medicine physician training committee. And so I have made sure that the nuclear medicine physician curriculum actually reflects the RSAC needs. So if anybody's wanting to do nuclear medicine, they can always use the nuclear medicine physician curriculum to see the level of education and case exposure that is required. Evidence of education can be presented from a variety of sources, or, forgive the plug, the Brighton and Sussex Medical School postgraduate multidisciplinary nuclear medicine course has recently started. We're in our third year, but that follows on from about 30 years of previous experience at King's. And I will just add the QRS code at the end if anyone's interested. I thought I would just show how radionuclide radiologists and nuclear medicine physicians sort of have common grounds, many common grounds, but also how their training is done. So I'm a radionuclide radiologist. I'm not a nuclear medicine physician. So I did FRCR, and I've got a comprehensive radioisotope diagnosis experience. And that is the same for nuclear medicine physicians who now currently are also radiologists. The difference is that radionuclide radiologists do not do any radioisotope therapy. And to prepare for that, nuclear medicine physicians have to have a medical background, or at least a broad clinical background, and also the nuclear medicine diploma. This is the conventional route for nuclear medicine physicians. So they do foundation year, internal training, medical training, and MRCP or a surgical equivalent. Then they do 3 years of FRCR and 3 years of nuclear medicine before finishing with a dual CCT in nuclear medicine and clinical radiology. Now, it is possible for people who are clinical radiologists who also have that medical training, this part, to actually switch to nuclear medicine training at the end. So they have exactly the same length and breadth of training as nuclear medicine physicians, but they've come from the clinical radiology side. These are the centres across the UK that support nuclear medicine physician training. So these are the centres that will have comprehensive nuclear medicine diagnostic training as well. But there are, of course, many centres which provide good nuclear medicine diagnostic training. I would just advise people who want to do nuclear medicine to make sure that they've checked the RSAC notes for guidance and make sure that they have a good comprehensive training. I think it's quite difficult to combine nuclear medicine training as a radionuclide radiologist with another specialty. I think it's too challenging. Thank you for listening. This is the QRS code for the Brighton and Sussex postgraduate course, if anybody finds that helpful. And I hope that was interesting, and I look forward to hearing your questions a little later. Thank you.
I hope everyone's had a nice short break. Welcome back. So thank you again to Dr. Fowler for that really interesting insight into nuclear medicine. And now we move on to the second half of the session, which will be on breast imaging. And we're very lucky to have Dr. Trupti Kulkarni with us this evening, a consultant radiologist in breast and head and neck imaging. So Dr. Trupti Kulkarni is a consultant radiologist. She specializes in breast and head and neck imaging and works at the University Hospital of South Manchester. She holds the position of Trust Specialty Tutor for Radiology at Manchester University Hospitals. In addition to her clinical roles, Dr. Kulkarni is actively involved in medical education and professional development. She also serves as the training and education representative for the British Society of Breast Radiology and contributes to the advancement of radiology training and standards. Dr. Kulkarni also engaged in public education. She's authored several articles aimed at debunking myths and providing accurate information about breast health, which can be of some sort of concern in the community. So without further ado, I'll introduce Dr. Kulkarni, please.
Okay, if I'm running short of time, please let me know. I do appreciate that all of you are here on this Tuesday evening, giving your precious time. And thank you so much for organizing it and for calling me. So I am Trupti Kulkarni, and I'm going to talk about breast imaging. Why consider it at all? And if I had a choice, would I choose to do it again? I would. You should too. So that's who I am. I'm a consultant breast and head and neck radiologist. I'm also with the University of Manchester, and I'm TPD for the NWSOR, and I work with the BSBR, and I do voluntary work, which is very interesting. You can do all of that. So learning objectives today are to learn about breast radiology as a specialty, to see what the responsibilities of the breast radiologist are, to look a little bit at the pathways to breast radiology. I suspect you do know it, but there are a few lateral oblique kind of ways to get in as well, which might be of interest, and to discuss any additional roles that may be undertaken by you as a breast radiologist. I must say, breast radiology puts you in a very unique position because you're dealing with not just patients, you're dealing with a whole team of clinicians, a whole team of allied healthcare professionals. And it's a very interesting way of working, and it really equips you to deal with a whole lot of stuff and puts you in pole position for being trainers, for being managers, you name it. It's really good fertile ground for it. So the responsibilities of a breast radiologist on a day-to-day basis, the one-stop breast clinics, assessment clinics, breast MDT, cross-sectional imaging, any image-guided procedures, whether with CT, mammo, ultrasound, usually it is ultrasound guided, peer reviews. Interval cancers are something very specific to breast, in that when patients have screening mammograms every 3 years, in between those 3 years, if they land up with a cancer and they come to a symptomatic service, we look back at the screening mammogram to check if a cancer was missed while it was really small, and we essentially review all our cases and feedback, not just to ourselves, but we talk to the patient and we tell them what the outcome of that was. Fortunately, it is very rare that we actually miss a cancer, but there are learning points at times. There's a special tool called Performs, which breast radiology uses for self-assessment. All of us use it as a self-assessment tool twice a year, and it tells us where we are with respect to our performance, with respect to our peers all over the UK. And in a way, it gives us a bit of practice and tells us what our blind spots are. For example, I might be one to miss small areas of microcalcification. So it tells me to just be aware and to be more cautious about picking those up, just as an example. And of course, audit of our practice as part of the NHS breast screening program. Opportunities, I would say, instead of using the word challenges, research, clinical research, there's a lot of that going on, including things like the small trial where we are excising small breast tumors, breast cancers, which are grade 1 cancers, less than 15 millimeters in size, using vacuum-assisted biopsy. There are lots of other research studies on, of course. There's, of course, artificial intelligence, and a lot of people, a lot of young trainees especially, worry about artificial intelligence taking over from radiologists, and especially breast radiology. And I would say, honestly, do not worry about it. It's not there yet, but even when it comes in, it's going to need someone to guide it. And yes, working will change. As a radiologist, when I trained, I did MR from from my inception in a way, but there were people who had not done MR before that. In the same way, there are AI courses that are now available, and I just see that the young radiologists of the future, perhaps 10 years from now, will be starting with using not just all the cross-sectional modalities, but also using AI. Someone's got to guide it. Someone's got to intervene when it actually goes wrong. There's a whole lot of work to be done. So please do not fear artificial intelligence. Embrace it and carry it forward, because it's the radiologist of the future that's going to do that. And breast is one of those that is absolutely at the cutting edge in terms of tools that are being used in a research setup at the moment. Team working, I already mentioned it. It's absolutely fantastic to be able to get feedback on the ground from your consultant surgeons. And honestly, there are no snarky surgeons with us. They are really nice. It makes a huge difference when you're dealing with somebody face to face, is what I find. As human beings, we are much more likely to be really nice to each other when we see each other. And it's a really nice dynamic that I see in breast units, usually. Tech use, you can use that in lots of different setups. That makes you quite adept at it. Please do pardon that I was not able to log in. That's different. Pathways to breast radiology, the usual. F1, F2, you could do an F3 year and then become a postgraduate doctor in radiology. Breast clinician, there's a breast clinician pathway where there are doctors who finished their MBCHB, and then they could train for 3 years as part of the National Breast Imaging Academy now and become breast clinicians, where they do breast radiology and also some surgical clinics and family history. So that's another alternative pathway into breast radiology. People who are either in the UK or including those who come from abroad, they can apply for the National Breast Imaging Academy fellowships and do a year as a fellow to embellish their training, and then they could apply as consultants in breast radiology. There is, of course, the certificate of training, which a person who comes from abroad can apply for to the Royal College and then become a consultant in breast radiology. Of course, I must mention other training before radiology, and I must mention this because I did 10 years of surgery before I saw the light. And that was a very interesting journey, I must say. So I would like to tell you about that journey in a minute. Let's crack on. What additional roles can a radiologist do? So there are educational, management, and miscellaneous roles, but really it's a whole plethora of things that you can do. Being CS, ES, training program director, head of school, regional advisor, there are RCR roles, the FRCR examiner, FRCR course examiners. I examine on a number of FRCR courses, medical student teaching, other specialty teaching. Again, OSCE examiners, I examine on the OSCE examinations for year 3, year 4, year 5 medical students. We are in pole position for communication skills workshops because it's something that we do on a day-to-day basis with our patients and with our staff, with our colleagues. Management, as director, risk and governance lead, audit lead, again, head of school, regional advisor, all these are part of management. I refer, being a part of that realm, exam support for the RCR, and of course, special interest groups like the BSBR, of which I am a part. So even as trainees, try to get involved. Special interest groups really do want to see trainees getting involved. It's a nice way to get into, in a way, a management role, in a way to see a specialty at close quarters. Other roles, you could become journal reviewer, editor, RCR representative on a consultant interview panel, which is again very interesting, and you're supporting, including a robust consultant interview panel and allowing really useful, effective candidates coming in. Also the ST1 and ST3 interview panels, medical student interviews, supervision for medical students, for quality improvement projects, helping medical students with their student selected placement, which puts radiology on the map. It encourages medical students to take up radiology. I'm an academic advisor for medical students as well. And honestly, I find that a really interesting and invigorating part of my portfolio. And really, it helps me in feeling young. Taster weeks for A-level and mature students, that's a very interesting part of life as well. And the appreciation, they're so grateful to you for whatever you show them. And that aha moment when the twinkle in their eye, that really says it all. And of course, various voluntary roles. So I also work with the Rotary organization, the Rotary, and I've done a few things with them. As a specialty, I'd like to start with talking about the evolution of radiology itself, then the evolution of treatment of breast disease, which of course impacted on breast radiology. Won't go into the details of this. We know that Ranjan discovered X-rays in 1895. How did it go on to breast? Let's just look at that. Does anyone know what X radis salutis means anyway? Have a look. It's interesting. It's part of our RCR logo. The evolution of treatment of breast disease. So breast radiology and breast surgery, they would, as you would expect, moved hand in hand, the other way in a way. William Halsted's breast surgery, 1894, was very radical. So it took away not just the breast and the lymph nodes, but also the pectoral muscle. As opposed to that, Veronesi advocated lumpectomy in the 1970s. And then when we went on to oncoplastic breast surgery, so less and less of breast was being taken, or even if the cancers were large, there was lots of local and distant reconstructive techniques that were being employed. And of course, this impacted on how we behaved as breast radiologists. So breast radiology, incidentally, was not even a specialty in its own right. And I would say surgeon Albert Salomon did actually quite a lot of significant work where he imaged mastectomy specimens and realized that radiology was quite useful at finding cancers. So this was quite seminal work in the year 1913. And going on to Philip Strax, who was a radiologist who worked very hard because he lost his wife to breast cancer. So he was instrumental in actually using X-rays to image the breast, and that's where it progressed from. In the 1960s, there was something called zero mammography, which came in. And then the first mammography machine came in 1972. And of course, the breast screening program was instituted in 1988. The British Society of Breast Radiology was established in 2014, and it sort of standardized the terminology for breast imaging in terms of whether it was benign or malignant, scales from 1 to 5 for ultrasound, for mammogram, for clinical examination, all of it. So, and then, of course, we moved from this ghastly thing, which is the fungating breast cancer, which is this is what it would look like on a CT scan. And we moved on to really tiny cancers that were picked up at screening. And of course, once the landscape had changed that way, there were different things that were expected of radiology. Why do we need to perform breast-specific imaging? You can see why we do, because, you know, that's the breast there, and obviously we're not seeing it very well. And this is the breast, and you can see how we see it. This is zero mammography. So it used a lot of edge enhancement, and it was a good technique, but it was very limited. And you can see that your MLO and CC views, you're not really seeing the pectoral muscle. It was very limited. As opposed to that, this is mammography, and what you're seeing there is, now I cannot help showing you pretty pictures, can I? So this is just the implant capsule from it's residual from this patient having had implants removed earlier on. What is a mammogram? I suspect all of you know it, but just a brief mention. It's an X-ray of the breast. The breast is compressed, and yes, the patient is told that the breast will be compressed. Most patients tolerate it quite well, you know, in case that's what's going through your head. Not a cruel technique. It's low radiation, and that's again something that you may be asked even as a very junior trainee. And it's performed in symptomatic women over 40 years of age, and screening, of course, from 50 to 70. There are some additional views, some more pretty pictures. And we always talk about, so these are implants, and that's an additional view called the Eckland view, where the implant is pushed back and we try to get as much of the breast as possible. Something that your patients may ask you in other clinical areas, you know, I have a breast implant. Am I okay with breast examination? Actually, breast self-examination is very good because they are able to examine themselves against the implant. Mammogram wise, yes, you're losing out quite a bit of detail where there's overlap. That's something that the surgeon who has done the implant originally should have told them. But in case it's something that they ask you, you know the answer now. We always talk about review areas in radiology, right? So for breast implants, one of the review areas, you know, when you see this huge elephant in the room, you forget about the rest of it, right? So one of the review areas becomes actually the breast tissue. And you can see this little fellow sitting here, which turned out to be a breast cancer sitting on top of the implant. Interesting place, isn't it? And for a biopsy, yes, I would tell the patient that I might land up damaging the implant. I didn't, coincidentally. So that was good. Densities. one of those things that are a conundrum, that are a challenge as far as breast radiology is concerned. Fatty, great. I can see everything. And I know that there's a little benign oil cyst that's sitting there. If it was all dense, though, I would really struggle. So the sensitivity of mammograms could be even 50%. So therein lies a challenge. That's a pacemaker, and of course, I'm losing a little bit of detail there. Again, another thing to remember, as in the rest of radiology, what's your coverage? That's important to remember. That's more dense. Now, and small cancer there, I'm not going to really be able to see it as well as I would have seen it here. Something to be aware of. Ultrasound, extremely versatile within the breast and within the axilla. And again, this is something that is important for the FRCR exam as well. You may or may not have seen a lot of breast, but there's a lot of information that's there on it. It tells you which breast, it tells you the axilla, it tells you which quadrant, which o'clock position, and lesions are lesions. Describe the lesions, you will get to your answer. Cysts are cysts, whether in the liver or the kidney or the breast. Describe it, you will get to your answer. More importantly, there are a number of solid breast lesions which are indeterminate. It's important to pick these up because they may be a cancer. Anything that is indeterminate, U3, needs to have a biopsy. It's a common sense reply, but those are your FRCR 2B marks. Cyst, anechoic, posterior acoustic enhancement. Solid lesion, pretty well defined, gently lobulated, still has posterior acoustic enhancement, and that is an irregular lesion which is breaking the continuity of your normal tissue and causing posterior acoustic shadowing to some extent, extending into surrounding tissues as well. So this is a cancer. That's probably a fibroadenoma, although it could still be a malignancy. I would biopsy it in anybody above the age of 25 or 30, and that is a cyst. If the patient is symptomatic, put in a needle, drain it, she will thank you. Lymph nodes. So we have the entire range from a normal lymph node there to an absolutely malignant lymph node where you can see that the fatty hilum is attenuated and there's a lot of cortex, so it's a malignant lymph node. And this is a completely replaced lymph node, which could be because of lymphoma. An example of a reasonably dense breast, but you can see that there is a lesion that is sitting in the upper outer quadrant. And what did we do? We did a biopsy, again, extremely amenable to ultrasound-guided biopsy. So procedures that can be done. We rarely do an FNA. It's generally core biopsies that are done. And we use a 14-gauge spring-loaded needle. You saw how it sprung down, so you know that now. The cores are sent in formalin, and FNA sometimes is used for deep within the axilla or where the patient is on anticoagulation, etc. A little bit about well, let me show you what lesions look like. So that is a reasonably well-defined lesion with a lot of calcification. That's typical popcorn calcification. That's a fibroadenoma. You don't need to put a needle into that. You could have previous imaging and that might help you, but really that is classic of a fibroadenoma. That lesion is an intermediate, as in, an M3 lesion. I really don't know. It's an indeterminate lesion. I meant indeterminate. And so I would go ahead and do an ultrasound and perhaps do a biopsy. As opposed to that, this is a Bandeau cancer. So you can see how it's a spiculate lesion. It's causing distortion, and that looks like a cancer. Yes, I would go ahead and do an ultrasound and a biopsy of it. A little bit about benign versus malignant calcification. You can see that here there is pretty regular linear calcification throughout the whole of the breast. This is benign secretory calcification. As opposed to that, you can see almost like a segmental calcification in this breast with various sizes, various densities, etc. And that's malignant calcification. Male breast cancer, yes, men can get breast cancer. And again, it's something that in a clinical setup, I would remind patients to examine themselves, including males. What does it look like? Just like female breast cancer. When is an MR of the breasts indicated? For breast cancer, yes, but not for all. Things like lobular, or where we suspect multifocal or multicentric cancer, or where we have found nodes, but no definite primary. And again, it's one of those exam questions. It can be used for sizing of mammographically occult cancers, can even be used for your 2A questions, okay? That is a mammographically occult cancer. How do we know there's a cancer? I'm telling you it's there, so it's there. But, we've actually biopsied it under ultrasound guidance, and I've put in this mag seed, which is a magnetic marker, so that the surgeon is aided in actually removing that lesion while they're operating on the patient with a wide local excision. MRI can also be used as a baseline for patients receiving neoadjuvant chemotherapy to look for tumor response. and for detection of cancer in dense breasts. That was one of the things that I mentioned. It's one of the challenges that we face as breast radiologists. So this is a lobular cancer, and with the eye of faith, you will see that there is a little bit of a density there, which was the area of the cancer, perhaps that on the CC view. It's very close to the nipple. It's about 10 millimeters from the nipple. And I told you we do an MRI scan. Why do we do it? Because this could be multifocal, and indeed it is. This is an example of multicentric cancer. You can see that there are a few areas, and you can see much more on the MRI. You're also seeing this abnormal lymph node here. Inflammatory cancer. Why is this important, and why am I actually mentioning this? Because it's one of those things that can have an overlap with things like mastitis. And particularly women who are breastfeeding, lactating, when they come to perhaps the A&E and they come to a general radiology department with, for drainage of an abscess, this is one of the things that can come up. The overlap between inflammatory cancer and inflammatory breast cancer and mastitis is real. And it is important to recognize that and to ensure that the patient does go to the breast unit. So this is what it looked like on ultrasound. There was a lot of skin thickening. There's an irregular mass that's sitting there, lots of skin thickening. That is pathognomonic of inflammatory breast cancer. Of course, the word inflammatory breast cancer is a clinical term because the breast is red and hot. It's not something that you say on radiology. What you can say is that there is extensive skin thickening and a lot of this vague hypoechoic change throughout the breast. In fact, here you can see on the mammogram, the breast looks quite distorted. It looks quite dense. The pectoral muscle looks like it's been pulled by this density that is sitting in front of it. And that was the entire breast was occupied with the cancer. Again, interesting stuff. MRI of the breasts for an implant. That particular implant looks the way it does. Of course, it has folds, but it has saline in it. And that is the reason why it's looking the way it does. MRI is also used for high-risk patients like BRCA genes, etc., and for surveillance of mammographically occult cancers and suspected implant rupture, which is what I'm going to show you. So that's a normal implant and the area of interest. So the patient was feeling this little fold, and ultrasound is enough for it. And we've done the ultrasound. I've told her that it's just an implant fold. That's it. There's nothing more that needs to be done. So not every patient that has an implant needs an MRI of the breast. This one has intracapsular rupture. You can see lots of lines parallel to the implant capsule. That's the implant capsule. That's the body's shell. The body lays down a shell, the implant shell, and the body's capsule, sorry. The body lays down a capsule around the implant shell. And you can see that there is a lot of hyperechogenicity within. So this was intracapsular rupture. Now this is extracapsular rupture. You can see that it's actually broken in parts, and there are areas of silicon that are lying outside. In this case, they are within the lymph nodes. This is called a snowstorm appearance of lymph nodes, indicating silicon granulomas. An MRI showing you a rupture. This is intracapsular rupture. You can see the spaghetti sign. And again, on a sagittal view, here again, you're seeing intra and extracapsular rupture. You're seeing lots of lines there, and you're seeing all this hyperechogenicity within. That's silicon within the lymph nodes. What else do we use breast imaging for? And again, there is a lot of therapy that we can do with this. So this is a really large seroma that developed a few years down the line from having had a breast implant. And again, this is important because this might come to a general, radiology or general to the A&E. And it's important to refer these patients to the breast unit. And when we aspirated this and sent it off to the lab, this turned out to be lymphocytic, it was a ALCL, so a lymphoma, a large cell lymphoma. This was a mass seen with ALCL, a different patient. And of course, we biopsied that. That's what it turned out to be. Sometimes that can be seen with contoured implants a few years down the line. Another important question for your exams. A little bit more about postoperative imaging. What else can we see? This is a postoperative hematoma. You're seeing variegated echogenicity. The skin is thickened. They are postoperative. You're seeing some amount of anechoic material within, and perhaps you could target this under ultrasound guidance and drain it to allow the patient to feel better. If it's infected or appears infected, you can send it off to the pathology, to the microbiology lab as well. This is postoperative collection at the donor site. Remember, I mentioned that breast radiology has changed quite a bit because there are different things that are being done. And this was a tram flap that was done, and there was a collection in that area. Am I running late?
It's okay. It's 5 past, but I thought I'd let you talk. It was very interesting, and I was hoping you sort of also get to how you got into breast radiology, which I thought would be very interesting as well. But
Already
don't
over
worry, we're
time.
okay to run 5 or 10 minutes over, so it's fine.
Okay, fine. Okay, so this is just post-operative fat necrosis, and of course, you can aspirate the seroma. Debates in breast radiology, I spoke about breast density, and you're not going to be able to find a cancer there. It's actually a lot of cancer that's sitting there, and this was an invasive lobular cancer, and the MRI shows you that it's really extensive. Another debate in breast radiology: are we overdiagnosing, overtreating breast cancer? A challenge. I'm going to just leave that question there, okay? But I'm going to say this: breast radiology is not just for breast radiologists. And why do I say that? So I have a few cases here. And this was a cancer that was seen at cardiac imaging. And in fact, if you look at the mammogram, it wasn't seen on the mammogram. It was seen on the ultrasound because we knew there was something that was there on CT. So again, it's one of those things, review areas. Breast is a review area whenever you're doing your CTs. This was a cancer. Yeah, we can see that it is a cancer. She had staging and lots of lymph nodes sitting in the supraclavicular region, right? That supraclavicular lymphadenopathy. Another one, PET CT. So you could also see it on nuclear imaging. And there you go, about 55% of things that light up in the breast on PET will be breast cancers. And tiny little lesion there seen on CT, probably would have missed it. This was actually a MET from lung cancer. Young patient, she was that's my next one. So these are fibroadenomas, and again, nuclear medicine, you can see that they are not having any uptake, and that's our friend there, right? That's popcorn calcification of fibroadenomas. So this is a young patient with breast cancer, little lesion that's sitting there, palpable mass, and we thought it could be a sebaceous cyst, but it was this irregular area biopsied. It was a U4 lesion, and it was a triple negative breast cancer, and that's what is seen on the MRI image there. So my interest in breast radiology, I told you about challenges. I told you what makes it worthwhile in a way. I will tell you about the future that I envisage. Before that, I will tell you about localizations, because these are some of the challenges that we face. And given that cancers are now tinier and tinier, we deal with all of these things, the wires and the MAC-seed that I told you about, and all of these newer non-wire localizations, again, very important for your exams. So iodine seeds, radar reflectors, RFID tags, etc. That's an example of a MAC-seed introducer kit. Some more imaging advances: a vacuum-assisted biopsy takes larger sample cores, 9 or even 7 gauge for that, for example. This is automated breast ultrasound, and it's at the moment part of a trial, and you're just seeing the probe move over the whole breast. Of course, the radiologist needs to interpret this, and if there is an abnormality there, then I will need to recall the patient and actually do a physical ultrasound. Another bit of imaging advance, so the poor man's MRI. So this is a contrast enhanced spectral mammography that you're seeing there, as opposed to an MRI. So briefly, my interest in breast radiology, and so I trained as a surgeon for about 10 years, and then I realized that the radiologist was getting to the patient long before the scalpel was picked up by the surgeon. While it was great to problem solve and do things in surgery, I realized that a lot of things were being guided by radiology, and especially breast radiologists. So that's where my interest in breast radiology started. Did I have challenges? Of course, I had challenges. Once I got into radiology, I had a lot of problem with my hand-eye coordination. I am not ashamed of saying it. And I am very happy to say that, actually, because it made me a much better trainer, because I can see what trainees face. So if when a trainee has a difficulty with hand-eye coordination, or with doing a biopsy, or with doing a procedure, I can guide them, and it has really been useful to me. What other challenges did I face? Yes, the team working. At times that can be a challenge. The resilience that you need to show when you are faced with a number of cancers in the day, some of them really young patients, lots of patient stories that you have to shut the day, as you shut your laptop, you have to stop the day there, and then you go home and don a different hat in order to keep your sanity. And is it worthwhile? Yes, it is extremely worthwhile. All the things that I do. So this is part of the British Society of Breast Radiology. So this was planning the conference, and actually doing the conference and making friends, networking. This was the Kenya UK teaching collaboration. That was actually a picture I took on my iPhone. And I did go to the Maasai, but of course did a lot of teaching as well and connected with the locals. And this I did this day before yesterday actually with the Rotary. It was with the medical college in India where there was the lay population who wanted to know about cancer, and this was delivered in 3 different languages. And it was a very interesting part of my long bank holiday weekend. I went with the THET, which is the Tropical Health Education Trust. I went to Ghana in the month of June last year. And that's where quite a bit of MDT style teaching was delivered, including sustainability of the MDT. So we went there as a group of a surgeon, pathologist, radiologist, breast care nurse, and there were people who came from Ethiopia, etc. And delivering not just the teaching, but also how to implement the MDT teaching going forward. So we wouldn't have to repeatedly go there. And yes, I did enjoy that, drumming with the local drummers there. The Nigerian team visited as part of the MDT, as part of THET, and that's them in my humble residence. And yes, that was my whistle stop journey of breast radiology and why you should do breast radiology. And yes, I would do it again.
That's great. Thank you so much. What a great insight into breast radiology. So thank you, Dr. Kulkarni. And now I'd like to open up to the sort of the participants to for the Q&A session. If I could ask if you put your hands up and then we can sort of go in order and keep track of those questions, and please direct them to either Dr. Fowler or Dr. Kulkarni or both, if the question applies to both. I mean, if you don't mind, Dr. Kulkarni, could I just start off with the first question to you, please?
Yes.
So I was just wondering, you mentioned at the start AI and breast radiology. Do you see that? How do you see that fitting in with your practice at the moment? Like, is there? I know I've seen chest radiology. They have the nodules screening on CT chests. Is there anything like that in the pipeline for breast radiology?
Yes, so there is already a huge trial underway for, so breast radiologists, we double read our screen reading mammograms. So patients from 50 to 70 who get invited for screening, all of them have, the ones that come over have their 3 yearly screening mammograms, and we double read them. So having AI as one of the readers, and so a single read with AI and seeing what our pickup rates are like, whether they are better or they are worse, and how they compare with the actual prognosis and outcomes of the patient. That's something that is in the pipeline. There are places that are also doing things like patient prioritization for one-stop clinics. So when a mammogram is done, the patients that are more likely to have cancer, in a way, they go to the top of the list. So they get seen earlier. If they have to have biopsies and other investigations, they can start their journey sooner in the day rather than stay behind at the end of the day, and perhaps not have those investigations. So there are a few things that are ongoing. I don't
That's
know
really exciting. Yeah, no, that's great. So you potentially double the capacity for reading then.
In a way, yes, in a way.
Mm. And then we
Also,
have
mind you, you won't be losing your job as a breast radiologist, because what AI picks up, first of all, there has to be somebody else who has to moderate it and say yay or nay. Because if there is, say, for example, a scar, AI picks it up as potentially a cancer, but you know that the patient has previously had surgery, and then you can evaluate it better. Also, you'll be needed still to do the biopsy on the patient. And of course, the human touch is something that is needed.
Oh, definitely. And we have a question from Raz just on the chat. So this is for Dr. Fowler, I believe. Is there an established training pathway for just reporting PET-CT as opposed to doing radionuclide radiology? I ask as I have met a few consultants who only report PET-CT, but I wonder if this is now a defunct pathway.
So that's a great question. I have to say that RSAC, who kind of hold the key to whether people can practice as independent practitioners, don't really mind whether people have a comprehensive background. Everything is done on an individual tracer basis. I think it would be an unusual radiology department that would support a trainee in just doing PET, but it is possible. There are some centres and fellowships that you can do. And there are quite a lot of consultants who only practice sort of with FDG PET. The idea of nuclear medicine physicians is that people are comprehensively trained to deal with different, because there's not just FDG as a PET tracer, you know, there are lots of other PET tracers coming along. So the idea is to, you know, I would hope that nuclear medicine trainees, whether they are radiologists or physicians, looking at the diagnostic aspect, would try to get a comprehensive experience so that they'd be kind of future-proofed, because who knows what tracers are coming through the pipeline, and we need people to be able to be kind of flexible and well-educated in the broad so that they can pick up those opportunities in the future. But yes, you can. I mean, you can train to do small or large sections of nuclear medicine. It's a good question. Thank you.
Yeah, that's great. Thank you. Because I know as part of the MSK team, a lot of them report obviously the isotope bone scans, which is purely nuke med. Just out of interest, does the holder of the RSAC license within the, do they need to allocate and sort of officially say that these consultants can report PET-CT and isotope bone scans?
Yes, because reporting is actually an operator under IRMA. Sure, we all love to hear about IRMA. Under IRMA, you know, you have referrers, you've got the practitioners, then you've got operators, and actually reporting is part of an operator function. So that has to be delegated by the practitioner.
Okay, interesting.
So that is kind of how the system is meant to work, so that the person who holds the RSAC license then can decide whether people can report under them, under their license. And it's quite a big commitment, really. It's a big decision, because essentially the practitioner is holding responsibility for the quality of the reporting. So, yeah.
No, absolutely. Thank you.
This is why it's always really nice just to be the practitioner yourself and aim high with nuclear medicine training. And I mean, I have come across trainees who have kind of dabbled in it. And I don't know if there are nuclear medicine people who are training in radionuclide radiology here, but I think it's better to kind of go for it and really try to kind of nail all the different tracers, so that you can be a comprehensive RSAC certificate holder, or license holder, I should say.
Yeah, that's good advice.
Amy, you doing? Did I hear you doing nuclear medicine? Would you agree with that?
Yeah. So I'm in ST5 of radionuclide training within like the radiology arm, as you described. I would agree. Yeah, I think better to be an all-rounder. You want to be able to provide an expert opinion kind of from a nuclear medicine department, more than just on like an isolated test. However, the Northeast has seen people independently just go and do FDG PET because of service need over the last 10 years or so.
Yes.
So we had someone specifically do kind of onc-gynae cases, and someone else do head and neck PET reporting, because they were growing in the MDT at such an exponential rate, and there just wasn't the workforce in the Northeast to cover those MDTs with, you know, that kind of nuance that you need to be handling those quite complex cases.
Yes.
But I'm pleased to say that over the last sort of 3 years, we've trained 5 registrars in radionuclide radiology. I'm the 5th. And so I think our trainers are starting to say, look, we would want you to be doing the entirety of radionuclide radiology now, because we don't have that workforce need. But obviously, if it did resurface, you know, brain PET, for example, is such a growing area for us that we're not really keeping up with.
Huge.
That sort of thing. Yeah, if the workforce needs drive it, then maybe people would want to do it. But I would always try and learn, you know, as much as possible, you know, have the breadth there, and you can always do less. as long as you've got it kind of in your back pocket. Whereas if you are quite specific from the start, then you get, doors are a bit more closed.
Thank you. And I think we have time for one final question to Dr. Kulkarni, which is, does one face more medico-legal litigations in breast radiology in your experience compared to other system-specific radiologists?
I am so glad you asked that question. That was part of the challenges bit that I was going to put in, but I didn't have time. So, well, actually, no is the answer, because it depends on how you interact with the patients. And the truth is, what you bring to the patient interaction really guides what the patient feels, and if they think that something has been missed. It's not actually dependent on whether something has actually been missed. It is how the interaction has gone. And if you've listened and you've been kind and polite and of course done your best, they do not, even the ones that I tell you about, the interval cancers and things, we have to recall the patient and say, this is what has happened, and this was our learning point, etc. But more often than not, they will not complain about things. Yes, there will be the odd one that will, and many a times when we look at our practice, we realize that actually the correct procedures were followed as well. So it is no more than the rest of radiology, is what I would say. And certainly in my practice, I haven't really seen more than, and I have done general radiology in my first 2 years, so certainly not more than. So thank you for asking that question. Another thing that I would like to tell trainees is that you can combine breast radiology with something else. There are lots of transferable skills. And like Scott was saying, MSK with breast, that's great. I do head and neck with breast, and it really lends itself very well because you're throwing needles everywhere, and it's absolutely fantastic. People love you for it. What's not to like? So you can join breast with something else as well. Yeah,
you can of course join nuclear medicine with something else as well. It's difficult to do it while you're actually training. So I'm also cardiac, and that fits very nicely. Yeah.
So in both subspecialties, you can do post CCT training under guidance of another consultant.
You can. I did cardiac training as a consultant, and that seemed to be fairly straightforward. I just think nuclear medicine is a bit more challenging. I would just get as much under your belt as possible while you're a trainee, and try to get a comprehensive list. That's what a diagnostic radionuclide radiologist should be achieving during their 2 years of training. So, I would just say you have to be quite assertive probably, and say, these are the areas where my gaps are, and I need to complete these.
Great, super, thanks for that. And I saw Dr. Kulkarni nodding there, yeah, super. All right, well, I think we'll bring that to a close. Amy, do you have anything else to add?
I was just going to add on a positive note that coming towards the end of my training, you start to realize there's still a lot to learn. And so just to take the pressure off people who are deciding and feeling like it's such a massive decision, which I know I did think it was, but you see great examples of consultants who are still training post CCT, and there's always opportunities to learn more and do more and maybe segue into an area that you didn't quite expect. So in a way, I know we're all trying to make a decision about what to specialize in, but maybe think about that in terms of it's not so much pressure. There's always changes you can make downstream.
I totally agree with that. And my first job was in a DGH, and I did a lot of intervention. I was the nephrostomy queen. So, you can go off in different directions, and it's wonderful, isn't it, to have a career where actually variety is the spice of life. And I would encourage people to take different routes through, because you're going to be working for a long time, and it's great to have different experiences and to pursue different interests.
Yeah, exactly. And I'll finish just by agreeing with that. I mean, the breast radiologist who sort of inspired me, she did MSK for 10 years post CCT, and then did a complete flip, and her job plan now is 80% breast, and she eventually wants to give up her 2 PAs of MSK. So I just think that's great. And like you say, the career owes itself to great flexibility. But thank you again to Dr. Fowler and Dr. Kulkarni for those really great talks and insights into each subspec, both nuclear medicine and breast imaging, respectively. I'd like to finish with that, please.
Thank you. Thank you for the opportunity. Good luck, everyone.
Thank you. All the best.